because that's something I never want to forget that. And then when it gets close to time, I'm like, did I hit that record button? Yes, I did. So we will be getting started in just 1 minute. All right. Well, good afternoon, everyone. I'm Kristen Flewitt. I'm the Senior Quality Manager here at the Ohio Chapter of the American Academy of Pediatrics. Thank you for joining us today for the second webinar in our Ohio Pediatric Psychiatry Access Line webinar series. Today, we are going to have a case review. Today's session will be recorded, and you will receive a link to the slides and the recording. Thank you to our project sponsors, the Ohio Department of Health, the Ohio Department of Medicaid, Ohio's Medicaid Technical Assistance and Policy Program, and Ohio College of Medicine Government Resource Center. A few housekeeping items. Please stay on mute to minimize background noise. We will be monitoring the chat for questions, and we also have some time at the end for questions and comments. Please remember to turn on closed captioning if you would like. The Health Resources and Services Administration, known as HRSA, provided financial support for OPPAL. You will be able to read the award amount on the screen. The contents of the presentation are those of the authors, and they may not reflect the policies of HRSA or the U.S. government. Today's presenter is Dr. Mary Gabriel. She will be introducing herself to you shortly when she begins her talk, but we are incredibly grateful for her expertise and all the wonderful things she's done for the OPPAL project. A quick disclosure, the planners, faculty, and others in control of the content have no relevant financial relationships with ineligible companies, and the presenters have considered the Ohio AAP Speaker Toolkit standards in preparing the presentation. It is always our intent to foster respect, belonging, support, and accountability. If you should happen to have any concerns or comments on today's webinar, you may contact Kelsey Logan, and her email address is on the screen and will be included in the slides that I'll be emailing out to you. With that, I wanted to turn it over to Dr. Gabriel, who can review the objectives for today and get us started. Thank you so much, Dr. Gabriel.
Thank you, Kristen, and thank you so much for that generous introduction. I appreciate that. Good, I guess it's afternoon now. I'm Mary Gabriel. I'm one of the child psychiatrists here at Rainbow Babies and Children's up in Cleveland, Ohio. I have done child psychiatry for now 15 years, but before that, in my other life, I was a pediatrician, and I practiced primary care pediatrics for almost 10 years before coming and retraining in child psychiatry. So it's been a nice sort of marriage of all of that education and really sort of building a perspective on children that is definitely more holistic than I think either separate training would have granted me. So I'm really excited to be putting all of this together, and I'm delighted to join you this afternoon to talk about ADHD and how you would treat various situations in your practice, especially seeing different modifications of medications and using them to your advantage. So today, I definitely want to go through the various classes of ADHD medications and their formulations, because again, you can use those and modify them according to the outcome that you need clinically. By the end, it would be my goal for you to feel comfortable with at least 2 different stimulant medications, as well as knowing when a non-stimulant medication is appropriate or inappropriate. Certainly knowing when side effects arise and being able to speak to those and then manage them effectively. And then really sort of being able to distinguish between ADHD and other conditions. Inattention and hyperactivity can both be very sort of generic non-undifferentiated symptoms. And we find that there are a lot of disorders that might
Oh my
have
God.
low concentration or hyperactivity. Oh, should I heard. Okay. So I think it's really important because using a stimulant medication for something that is not ADHD might lead to results that you weren't necessarily looking for. So next slide. All right, so we're going to open with a case, and this is a real case. The intention was to present cases that we are getting through the OPPAL consult line, which has been a lot of fun to help launch with all the other children's hospitals and with ODM, ODH, and the GRC. However, it was sort of a slow start, and so in preparing for this case, we decided to go ahead and use a real case that we have worked through when we have Rainbow Echo. So Nationwide and Cincinnati Children's, as well as Rainbow, each of us have an ECHO program that is focused on education for mental health for anyone who treats children. And so people bring a case to discuss, and this is one of the cases that actually engendered a lot of good discussion. So, background. This is a patient who you've never seen before, who was previously managed by another PCP, who has since retired, so they are not available to ask questions. It's starting. You have a 12-year-old new to you patient who has a history of ADHD, and the chief complaint is that medication doesn't seem to be working so well. Patient was brought in by their grandmother, who they live with, and she says that she sees some difference after taking lisdexamfetamine, which is Vyvanse, but that she still doesn't really sit still and struggles to pay attention. She's barely passing. It is really hard to fall asleep at night. She just can't settle down enough to fall asleep. And then because it takes so long to fall asleep, she's very difficult to wake up the next morning. And then even trying to get the medicine in her can be very challenging. So this is what grandmother is bringing to you as a problem at home. Next slide. So a little bit more information. She mentioned sleep. Grandmother says it's really always been an issue. They have tried to do sleep hygiene, making sure that she's got consistent bedtime and wake time. There are no daytime naps, having some routine. But she says it could be better. They could be a little bit more structured about it. And then behavior-wise, she does say that this young lady does respond to positive reinforcement, which has been challenging for her in the past at home. Next slide. So you decide, okay, well, you used to see another PCP. What were they doing before? And so you find this. There are medications listed. It doesn't necessarily tell you why they were stopped. So this patient was diagnosed at 7, and they were started on methylphenidate extended release formulation Concerta, and they were on that for about 2.5 years. They got up to 50 more milligrams. And then the first switch, they changed to Ritalin LA and got up to 30 milligrams per day, but because of shortage, and that was due to shortages of Concerta. And so they were on that for just shy of a year. And then they switched again to Adderall XR, which was not clear why they switched to a different sort of subclass of stimulant medication. That was going on for 2 months. And then they switched again to now taking Vyvanse. So this is the history that you are given. Next slide. And then just some additional history, past psychiatric history, like she's never had therapy, she's never been admitted to the hospital, there are no other comorbid mental health conditions. Past medical history, just to make sure that nothing else is going on. She's got a ferritin level pending because sleep medicine had seen her and was concerned about restless leg at night. And then family history is pertinent because mom herself has ADHD. Next slide. However, we don't know what mom was treated with. So, social history. She does live with her grandmother, mainly because mom's has some limitations financially that make it really difficult to support both of them. And patient really likes living with her grandparents. Grandparents are not the guardians, however. Mom is still a guardian, but grandparents really sort of manage her day-to-day life. Education, we talked about not having super high grades. She attends an online school, and she really wants to go to a brick and mortar, like in-person school. She misses being around kids, but mom was not interested in having her do that. She wouldn't allow going back to back to in-person school. And then in addition to that, when she was in in-person school and online school, the teachers note that her attention is pretty poor. And it is very difficult to maintain concentration regardless of the content that's being taught. So there's no real preferred subject matter. She's never been assessed for any learning disabilities. There's no educational testing or psychoeducational testing that has been done. So we don't know if there are other confounders at play here. No history of trauma. And she's actually a very active young lady. She has a lot of extracurriculars. She's very athletic, and she really enjoys participating in sports. Next slide. So, all right, well, that's the history. What do we do with this? She's on Vyvanse. It's not going so well. Well, let's look at medications. Next slide. So ADHD medications, really we categorize them in two buckets. One is the stimulants, the other bucket is non-stimulants. Within the stimulant category, there are two other subcategories, methylphenidates and amphetamines, and we'll get into the differences between those two. And then non-stimulants, there are a list of medications. There are some categories in there, which we'll go into later, and particular situations when you might consider one or the other versus another option. Next slide. So, what to know about stimulants in general? Generally, they're effective. 70 to 90% of children with ADHD will respond to a stimulant, which is a pretty significant effect size. Most medications do not have as high an effect size as like 0.9, which a lot of stimulants do. So if someone truly has ADHD, there is a good chance that they will respond to a stimulant. Stimulants, how do they work? They actually either block reuptake of dopamine and norepinephrine, or they actually enhance release of norepinephrine and dopamine. Really, the ultimate goal is to increase the synaptic concentration of both of these neurotransmitters so that they can facilitate regulation of attention and impulse control. Not every stimulant works for every child. And sometimes it takes a little bit of trial and error to figure out which one might work better. I will say there can be a genetic component to response to a medication. So if a patient has a sibling who has been on a few trials and is doing really well with one particular medication, I might consider that as my first trial. Or if their parent has ADHD and has been on medication, we might consider that to be the first trial. So I think because they are stimulants and people are a bit cautious because, understandably so, we are now impacting a child's brain. We want to be safe. And so the mantra in psychiatry with medications is start low and go slow. So for stimulants, that holds true. Additionally, because there are two main formulations, there are immediate release formulations and there are extended release formulations. We typically start to be safe start with immediate release formulations. And then as you figure out what dose works best and the timing of that dose, then you can convert to a long acting. The conversion is not quite one-to-one for all of the medications, but as long as somebody tolerates immediate release, you can usually go to extended release. Some people start with extended release right away. There's nothing wrong with that. I will say, though, that younger kids tend to have a higher risk of side effects. And so if you start a younger child on a stimulant and extended release medication and they have significant side effects, well, now you've just subjected that child to 6, 8, 12 hours of side effects. Whereas if you started with an immediate release drug, it'll only be 4 to 6 hours. So that might be something to consider when you're trying to decide which formulations to use. Next slide. So we'll go into that first bucket, methylphenidates. Like I said, there are short-acting and there are long-acting. Like any medication, there are isomers. So there are levoisomers, which is the left side, and then dextroisomers, which is the right side. And in our bodies, the dextroisomer tends to be the one that is biologically active. So Ritalin has both. It has both levo and dextro, but we find that the dextro isomer, like I said, is the more effective. You might find that because they have levo isomer, that you might have more side effects than if you used a methylphenidate that is only a D isomer, such as Focalin. So Ritalin has both. Focalin only has the dextro isomer. And Focalin also has sort of the same sort of release technology as Ritalin LA, and we'll talk about that in a second. Getting into those long-acting release, there are a few mechanisms by which you have that prolonged release. The first of which is OROS, which is osmotic release oral system. And you see this mainly in Concerta. Concerta is a capsule. And I'm talking about the brand name because OROS was designed for Concerta. The generic formulation of Concerta does not have this, and so the bioavailability is a little bit different with generic than with the brand name. So just sort of keep that in mind when you're deciding which one you're going to use. The ORO system works in that there is an immediate release coating on the outside of the capsule so that you do get very quick onset, usually within 30 to 45 minutes. So you're not having to wait for medication to release and then be absorbed. However, after that initial coating dissolves, then you have this capsule which the osmotic, to me, the easiest analogy to imagine is a sponge that is dry and shriveled. And you stick this little sponge in the capsule along with the medication. You swallow this capsule, and through perforations, fluid enters into that capsule. And what happens to a sponge when you drop it into water? It starts to absorb the water and it expands. And so if this sponge is contained within a capsule, as it expands, it pushes out the medication through these perforations. Usually there's one, but there could be a couple. And so over time, you're pushing out this medication, and that is the extended release effect of an ORO system. Now, having said that, the capsule does not necessarily dissolve. So we've had parents come in and say the medication does not do anything because every time they poop, I find it in the toilet. Well, that makes sense because the capsule does not dissolve. We expect you to find that. That's the way it was designed. So if you hear something like that, just sort of keep that in mind. Then there are sustained release and extended release formulations of methylphenidate, and you can see it in sort of different ways. It's a little bit slower onset of action compared to the immediate release, and serum concentrations tend to be a little bit lower. They last a little bit shorter and can be less effective. So I tend to not pay attention so much to sustained release formulations, but I do look at CD, LA, and XR. And so the reason I say it is because the LA version is an extended release formulation, Ritalin LA. It's dual pulse release called SOTUS, which is spheroidal oral drug absorption system. And what that is, it's a mix of beads. Some of these beads within the capsule are immediate release. Some of those beads are delayed release, and they are released usually 4 hours after you swallow the capsule. And the way this happens is you swallow the capsule. Capsule is in your stomach, which has a pH of 2, and you get that initial burst. And then as the capsule travels through your small intestine and the pH gradually increases. You hit a certain pH, and then that delayed release sphere starts to dissolve, and you get a release, a second sort of pulse of medication. And so keeping that in mind, if you have kids who are on proton pump inhibitors or anything that might really impact the pH of their stomach, just sort of keep that in mind when you're looking at these types of formulations. And that's not the only drug that is like this. And so I would just sort of keep that in the back of your head. Next slide. So to describe sort of visually what's going on with the releases of medications, I'm going to start with this orange line. This is Ritalin immediate release. And so you take a medication, you take a dose in the morning, and you get an increase in your serum concentration, and then you gradually decrease it. Because this is immediate release, like, it would just slowly fade out after 4 hours. But the school day is longer than that. So many kids who are on immediate release Ritalin have to take a second dose in the middle of the day. And so here is this second spike, this BID dose. And then gradually you come back down after several hours. Compared to Concerta, which is this bright green line, you take the medication, here is that initial burst, that outer coating of immediate release, and then here is that gradual increase as that sponge expands and pushes medication out over time. And so just to sort of, and then here's the LA, the red line, which has the two different kinds of beads. So here is that first bump after the immediate release beads dissolve and then gradually increase, and then, oh, the capsule hits that magic pH in your small intestine, and then you start releasing the delayed release beads. So that sort of gives you an idea. A lot of people, if they're old enough to describe, they do not like this seesaw effect of repeated dosing of immediate release. And that's why extended release is such a big deal with stimulants. It is really difficult to suddenly become really attentive and then sort of slow back down and feel sluggish now that it's getting harder to focus, and then boom, you suddenly take another dose, and because you still have residual, you have more concentration later on in the day than you did in the morning. So just sort of keep that in mind when you're deciding what to use and when. Next slide. So I mentioned Concerta, Ritalin, Focalin, but there are other newer formulations that have come out that I think are really important to know. Because they are newer, they can be more expensive. So for an example, Abtensio is like $120. Some of these are like $300 and $500, whereas extended release methylphenidate is around $35 generic. So also, again, keeping in mind sort of what types of insurance, what is the financial situation for a parent. You've got different options that you can consider, and so all of these are factors that we take into account. So Quilivant, the big thing about Quilivant when it hit the market was that it was a liquid. I've been talking about capsules and tablets and pills this whole time. This was really exciting when it came out because now we could start using stimulants in kids who really could not swallow tablets and did not like when capsules with beads were opened and sprinkled on like soft foods. They wouldn't take them. They'd crunch down on the beads. It would be a mess. So this was really helpful when it came out. And then they came out with a chewable version as well. And so that was really exciting too, because it's hard to take liquids. They slosh around, as you know. Much easier to sort of take a chewable tablet. Contempla is also an oral disintegrating tablet, ODT, dissolvable methylphenidate. It's got an immediate release and an extended release formulation within the tablet. Abtensio is it's a multi-layer bead. It provides rapid onset and then a long duration of action because of the multi-layers. It can be opened and sprinkled, these beads. I would say these beads too. There are some formulations where this multi-layer bead, rather than having beads that are immediate release and then other beads that are delayed release, all the beads are the same in something like Abtensio, which is similar to Adderall and Mydayis, which I'll talk about in a few minutes. A good analogy is to think of a jawbreaker. When you have a jawbreaker, there are layers of flavors and colors within that jawbreaker. That is the same way that this formulation is made. These beads have layers, and as you hit different pHs, as it travels down your intestine, the layers dissolve. And that's how you get extended release of a multi-layered extended release bead. Jornay, I'm going to go to the next one, is really kind of exciting because it was the first medication that was so delayed that you could dose it at night so that you have onset by the time this child wakes up in the morning. As you've probably heard from some of your families, it can be really difficult in the morning to manage everyone, especially when you're waiting for a stimulant to kick in. If there is a high level of distress for a family in the mornings, I would consider something like Jornay. It has been really effective. Some people will use the Daytrana patch in the same way. I've recommended, like, you could go into your child's room an hour before they're supposed to wake up, slap on the patch, and then in their sleep, and then when they wake up in the morning, it is on board and working. And so it makes the mornings a bit gentler. Now, I will say, with a patch, you can't forget to take it off at night, because then this child will never fall asleep if they still have a stimulant going. So that also needs to be kept in mind. And then I'm going to go to Asteris. It's a methylphenidate prodrug. And this is sort of similar to Vyvanse in that the drug that is in the capsule is not active. It has to be metabolized in order for it to be active. I will say that the FDA consensus is that there's no real benefit over a prodrug versus an immediately available formulation. So I would say you could use it if you want, but I don't know that it's necessary. And so since this is dexmethylphenidate, this is basically a different formulation of Focalin, and I'll show that on the next slide. So here you could see, so the blue is the spike of Focalin, the initial immediate release, and then the second delayed release bead. The red line is Asteris, which is you get that immediate release for the dexmethylphenidate, and then the serdexmethylphenidate, the prodrug, this is where it starts to get metabolized, so you maintain this sort of gradual level that slowly decreases over the day. And so that's really the difference there. Next slide. How do you know which drugs are released, how and when? This chart, which I think is familiar to almost all people who treat children in a primary care setting, is all the stimulant drugs that are made for ADHD. And if you look at these different cells along the row, you will find it described how this is formulated and what you can expect when you give it as far as pulses of medication. So there is another place that you could find this information, and it's usually in the insert. Next slide. If you go to the prescribing information, you will see these graphs that describe sort of what the serum levels look like after you take a medication. If you see this sort of biphasic 2-hump, then you know that it's usually an immediate release followed a few hours later by a delayed release, like another pulse. So that's another way that you can tell. Next slide. I wanted to include a screenshot of this medication chart. This is widely available. It is free in the public domain. You can get laminated color copies if you'd like. But it is all the medications that we have for stimulants in ADHD. And it has a lot of really good information here in the various boxes. I'm not going to go into this, and I apologize it's small, but I just really wanted to let you know that this is out there and easily referenced. All right, next slide. So we're going to go to the next subclass of stimulants, which is the amphetamines. And amphetamines are they are also short-acting and long-acting. Adderall is a mixed amphetamine salt versus Dexedrine, which is purely the dextroisomer of the amphetamine. And so some people will argue that Dexedrine actually has fewer side effects than Adderall does. Yeah, honestly, every patient is unique, and I just go according to whatever the patient is experiencing. There is another formulation of an amphetamine called lisdexamfetamine, and this is another prodrug, meaning whatever is in the capsule is actually not active. It has to be metabolized through the liver in order to be activated. So I would keep in mind that the P450 cytochrome that is utilized can include the different cytochromes. One of them is 2D6. 2D6 is very popular in psychiatry because it metabolizes quite a few of our drugs, and there are different alleles. There are fast metabolizers and there are slow metabolizers. And I will tell you, there are some times where I will give a child an extended release formulation and it is completely gone within 4 hours. And you're scratching your head trying to figure out why, but you start to ask them more questions and you realize they are a rapid metabolizer and they actually just need either more doses throughout the day, or sometimes you can get away with staying with the dose and just increasing it so that they have a therapeutically available level for a longer period of time before it drops beyond that, under that threshold. So those are the main amphetamines. Next slide. There are some newer ones, just like the methylphenidates. Zenzeti is, again, this is purely the D-isomer of amphetamine. It is only short-acting, but it's kind of nice because it goes down to 2.5 milligram increments. The lowest dose of Adderall is 5, so if you wanted 2.5 of Adderall, you'll have to split the tablet. Procentra is a short-acting liquid, which again is nice because we've got all these pills and it's nice to have a liquid option. Adzentis is another oral disintegrating tablet. They also have a liquid formulation. It is the equivalent of Adderall XR, same micro particle technology as the methylphenidate oral disintegrating pills. Then Avikio is racemic and has used to have an ODT, but that's been discontinued. Dinaval is different in that the ratio of the different isomers is 3-to-1, and so remember the D isomer is more active, so this is arguably better tolerated and fewer side effects because you have more of the active drug in here. Mydayis is like an even longer extended release Adderall. So Adderall extended release lasts about 6 to 8 hours. Mydayis lasts 10 to 12, sometimes 14 hours. And again, this is the type of pill that has beads on the inside that are sort of like jawbreakers that have multi-layer. And so this one has 3 layers as compared to the Adderall XR, which only has the 2. And then their Adderall, the amphetamines also have a patch formulation, and that's Zellstrom. So next slide. So here again is the guide, and here are the patches over on the right-hand side, and you can find versions of this guide that divide the methylphenidates from the amphetamines. Next slide. So you can see here the 2 columns, methylphenidates and the amphetamines, and then it will also categorize them as short-acting, which is this view, and then next slide has the long-acting versions of both methylphenidates and amphetamines. Again, this is in the public domain and easily accessible. You can print it out yourself and or get color or laminated copies. So next slide. Side effects. So I would say, the next slide, most common side effects that you'll hear are appetite suppression and sleep problems. Some kids will have headaches when they first start, or sometimes stomach aches. As long as those are mild, I don't really mind it because typically the body adjusts and those actually attenuate after 1 to 2 weeks. However, if they are ongoing, or if the severity of the headache or the stomach ache is such that this child is now like losing function, that's not acceptable. I'm not here to torture you. Let me know and we'll switch. We have so many options. We do not need to stick with this one medication. So I have a little acceptance for some of these, but certainly monitoring closely is necessary. And some kids are really sensitive to medications. Some kids don't seem to mind whatever medication that you use. If you're having side effects, like I said, you can switch to a different class. I would keep in mind that side effects are more common, as I stated earlier, in younger kids and kids with developmental disabilities, including autism. So especially with those patients, I would start with very low doses and then gradually go up. Next slide. So how do you manage some of these? As far as appetite suppression goes, as the medication wears off, appetite comes back, and you will hear parents say they don't eat anything during the day, and then by dinner time, they are eating everything. Well, it makes sense. They're trying to catch up with all the calories they didn't have throughout the day. So I would favor calorie and nutrient-dense foods. Like, you want to get the calories in, but you don't want it to be nutritionally empty calories. So, rather than a bag of chips to get 150 calories, like how about some cheese and crackers, or how about apple and cheese, or things like this that are easy and that have some nutritional value. For kids who really have a hard time maintaining weight, I'll ask them, hey, you want a milkshake every day after school? And they get very excited, but it's not a McDonald's drive-through milkshake. It is at home with milk and a scoop of plain vanilla ice cream like Breyers with the 5 ingredients. If you want a squirt of chocolate syrup, fine with me, but at least I know they're getting good calories in that. I would also frequent snacking. If you can't get around the appetite suppression with these interventions, you might need to switch to a short acting so that it wears off enough for them to eat something and then they get that second dose. Or you can control better when it finally wears off in the day so that it's wearing off at like 3 o'clock in the afternoon versus 6 o'clock in the evening, and that allows for a larger window of time to get some calories in. And then just let them eat at night. They can have dinner and then they can have second dinner, or they could have a really heavy snack right before bed. So those are just some things to consider for appetite. Next slide, talking about sleep, again, just maintain good sleep hygiene. You can play around with, if you're on immediate release, you can play around with the dose, either the timing of that dose or the amount of that dose. And you can also, if you can give an extended release in the morning, and then if you need a booster in the afternoon, do an immediate release. I wouldn't do a second extended release because that'll interfere with sleep. And then certainly caffeine. I am shocked at the amount of caffeine kids are consuming these days, so that's always part of my interview with a patient is finding out how much caffeine they use. Next slide. Headaches and stomach aches, again, like I said, as long as it's transient, it's okay. If you suspect blood pressure issues, I would monitor. I have had patients who start to get hypertensive on stimulant medications, and so we absolutely stop and we switch to something else. Sometimes taking with food will help the headaches and the stomach aches, and then just follow up with them, and you can decrease the dose if needed. Next slide. Behavior. This is one of the other side effects that we will sometimes see. Kids, especially younger ones, sometimes you will find that they have mood shifts, particularly at the end of the day when the stimulant is starting to wear off. For some kids, it's really distressing. Like, they're tearful, they don't feel right, and they're crying, and they tell you they don't know why they feel this way, but they do not like it. And so for those kids, if you really suspect it's the tapering off or the wearing off of the stimulant, you can give them an additional small booster dose so that wearing off is a bit more gradual, and usually that'll take care of that. I would also make sure they're not hangry, so give them a snack, see if that helps with that sort of irritability and agitation. Or structuring something that would help regulate them, like a nap, some quiet time, some exercise. So I would just consider those. Next slide. Oh yeah, here's the mood lability that I was talking about too. Sometimes we crank the dose up because we're chasing attention. But then we get a higher risk of side effects such as mood lability. So again, I would just sort of start thinking about dose and timing, or even switching. Also consider that mood is impacted by sleep. And so we were just talking about sleep. These are stimulants, just like caffeine is a stimulant. That can interfere with your sleep if you take it too late. So if they're not sleeping and they are moody, I would address the sleep first. If the mood does not improve once you optimize their sleep, then I would start thinking about these other things. Next slide. And like I said, you can always change medications, not a problem. Next slide. Non-stimulants. So there are three main classes, I think, that we sort of categorize in our heads. The first is the alpha-2 agonist, the adrenergic agonist. Those are guanfacine and clonidine. The second is the SNRIs. Atomoxetine is the one that's been around the longest. Viloxazine just came to market maybe 4 years ago. 5 years ago. And then the other ones, which we don't use too often, bupropion I tend to use in adolescents, especially if they have a comorbid depression. And then tricyclics, I put this for completion, but we really don't use imipramine anymore for ADHD because we have these newer medications that are more specific. All right, next slide. So why would you use a non-stimulant? Some parents just don't want to use a stimulant. They have concerns about a stimulant in their child, which is fair. I mentioned the younger a child is, the higher the risk of side effects with a stimulant. So for preschoolers, I actually start with a non-stimulant if they have ADHD. If you need to add a non-stimulant as an adjunct, like you're getting partial response, but you can't go up in the dose anymore, it would be reasonable to add on a non-stimulant. If you are worried about diversion of a controlled substance for anyone in the house, including the patient, you can go to a non-stimulant. If they don't tolerate them, again, if you have comorbidities, you can be sort of smart about which medication you decide. If they have a trauma history, which I'll talk about in a second, and then again, if they're having some mood issues that stimulants would not contribute well to. Next slide. As far as efficacy, you can see that it is lower than the 0.9 that we associate with stimulants, so you might not get the kind of response that you would expect from a stimulant medication, but that doesn't mean that you shouldn't use these medications. I think in the right circumstances and dosing correctly, they can be very helpful. Next slide. So the two alpha-2 agonists, guanfacine and clonidine, both have immediate and extended release formulations. Both are pretty easily accessible. Oneida, which is the extended release version of clonidine that is not Capve, it's the liquid version. That is the newest medication to come to market. Sometimes that can be hard to find. So if so, you might want to just give your pharmacy a call and see if they have it. Next slide. So the other two medications we tend to use more commonly in the non-stimulant category are atomoxetine and viloxazine. They both target dopamine and norepinephrine, just like the stimulant medications do, but they're a bit more selective. They also sort of antagonize NDMA, and so glutamate transmission is impacted by that. Because you are affecting the receptors for the neurotransmitters, and you are changing the concentration of those receptors on the cell membrane, it takes a few weeks to kick in for these medications. They are not immediately acting like stimulants are. So it might take a month to get up to a clinically effective dose. The interesting thing about viloxazine, which came to market first in Europe and then in the United States, is that it also massages serotonin. And so when they have found some mood improvement when using viloxazine. Sometimes anxiety can improve too when you use viloxazine. They did do a head-to-head trial with atomoxetine, and they found that there was better clinical response to viloxazine. Response was faster, and there were fewer side effects. However, viloxazine is expensive, and not all insurances will cover it. And the prior auth process for this especially I've found to be particularly onerous. But if you need it, you need it. And if you really think a patient would benefit, I think it's worth going through all that. If you have dual diagnoses, I think these medications are definitely worth considering. So if you have tics along with ADHD, all the non-stimulants, I would consider guanfacine. If you have anxiety and ADHD, I would consider either atomoxetine or viloxazine. If you have PTSD and ADHD, I would consider one of the alpha agonists, guanfacine and clonidine, because it decreases sympathetic tone. And if you have somebody who's traumatized and is hyper-aroused, hyper-vigilant, hyper-alert, you do want to tamp that down a little bit, which the alpha agonists will do. So I would consider those. Next slide. I know we're running out of time over here. You know what? I'm pretty much at the end. The Wellbutrin, like I said, I use it in adolescents who also have depression, but be aware that if they also have an eating disorder, it is contraindicated, and it also lowers seizure threshold. So if there's any concern for seizure disorder that has not already been treated, I would probably think twice about Wellbutrin. So yeah, I'm going to stop there. I just have a couple more slides, but there are graphs and things. The other thing that I will point out, the differential diagnosis, here are the things that can look sometimes like ADHD that you might want to consider, but happy to talk about those as well in the questions. So I'll stop there.
All right, thank you so much. Do we have any questions at this point for Dr. Gabriel? If so, feel free to take yourself off mute and ask, or you can enter it in the chat. And there are some additional references, again, that will be in the slide deck that you receive. Again, we want to thank you for joining us today. And as a reminder, if you have not enrolled in the additional webinars included in this series, please be sure you do. We have some coming up, again, every 2 weeks for a bit, and we will wrap up with them in April. I think we do, let's see. No, I think we just had a comment that this was very helpful. We also have put the link in the chat to register for additional webinars if you haven't already done so, and I'll also include that in your follow-up email. So again, thank you, Dr. Gabriel, for a great and thorough presentation, and thank you to everyone who joined us today.
Thank you.
Thanks, everybody. Have a great day.
Take care.
Thanks.